Hello, and welcome to this conference hosted by the MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today with Dr. Ben Thrower, who's going to be with us for the next hour answering as many of your questions as we can, or as he can, actually. So now I'm delighted to introduce him. Dr. Ben Thrower, for all of you that don't know, is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly Focus magazine. When Dr. Thrower isn't dressing up as Jack Sparrow the pirate, he can be found playing with his two wonderful grandchildren named Sam and Opal. How old is Opal now?
Opal is 7 months. Yes,
Wow.
getting bigger.
And Sam is 5?
4 years old.
Yeah. 4. Oh, I'm making him older. Okay. Anyway, welcome everybody. If you have questions, let me just explain for those that haven't been with us before how the questions and answer session works. As a reminder, what we'd like you to do is if you have a question or a comment, you can just use the Q&A button in the app. It also allows you to send your question anonymously if you like. If you want to raise your hand and actually ask Dr. Thrower a question, you hit the, ask the question by, you raise your hand. There's a little button to raise your hand. And when I hit the button for you, you have to acknowledge and allow me to unmute you. So, and if you want to do it by phone, you just hit *9. Okay, so now let's get going. Let's see how many we have.
All right.
We have 2 questions already. So we can go there. Let's see. Is energy, and this is from Elizabeth, is energy expenditure significantly greater for PWMS versus others given equivalent activity?
Yeah, great question. And so I think the study that I'm thinking of came out last year. They did a little blurb on that in the MS Focus magazine. So she's absolutely correct. So people with MS exert more energy doing the same activity than a person without MS. And sometimes it's obvious. So if we think about, again, walking. So if you're struggling with spasticity or weakness and you're really, trying to get that leg moving, we can see people with MS sometimes just exerting more energy to do something. But it even goes into things like cognition, so if you're struggling with processing speed or word finding difficulty, you're burning more energy just with cognitive activities than a person without MS would do. We wish that translated, that the people have asked, well, does that mean I'm burning more calories? Yes. Does it seem to translate into weight loss for people that are trying to lose weight? Yeah, we don't see that, and I'm not sure why that is. It may be that the balance to that is because sometimes people with MS are struggling with exercise or finding appropriate exercises. They're not burning as many calories otherwise, when they're not doing daily activities. So, but the answer is yes, you are burning more energy.
And Gus says, hello, is there still a need or use for first-line therapies in Interferons, Plegridy, Rebif, Avonex, etc., and Copaxone? Also, do you have any information about the Delver MS trial? P.S. Greetings from Athens, Greece.
Awesome. So we've evolved over time, in what we have available to manage MS with disease-modifying therapies. I would argue that some of our more recently approved treatments, things like natalizumab or ocrelizumab, the S1P drugs like Gilenya and Zeposia, those drugs are probably, for the average person with MS, more effective than our original platform therapies, our Copaxones and Interferons. Those drugs may still have a role, though. So we have individuals who've been on interferon therapy since those therapies became available back in 1993. And if you're doing well with one of those original platform therapies, there's nothing to say that you absolutely have to move to one of the more recently approved therapies. most MS centers have moved towards using more aggressive treatments earlier. So I would say our use of those original platform therapies, glutathione and interferons, is less now than they used to be, but it's still nice to have them in the toolbox. I'm not familiar with the trial that he mentioned. If you can tell me what molecule it's looking at or what treatment, because all of these trials, these clinical studies have different acronyms, and sometimes we know them more by the substance they were looking at versus the acronym that the study was named. So yeah, if you can write that in a minute, that'd be helpful.
Linda's asking, what is your opinion on Evusheld? Has it been shown to be effective so far? Are there any significant side effects?
Yeah, so we are offering Evusheld. And for those who don't know, so Evusheld is a COVID monoclonal antibody. It's actually two antibodies directed against different portions of the COVID spike protein. And it can be used to treat people who have a serious COVID infection. It can also be used to prevent COVID infections. So we are offering it to any MS patient who we think may not make a good antibody response, either to vaccination or to natural infection. And that patient group is really going to include people on B cell therapies. So this is Ocrevus, Kesimpta, Rituxan, Truxima, and probably patients on S1P oral therapy. So this is Zeposia, Ponvory, Mayzent, and Gilenya. So what's research has shown is if you're on one of those classes of drugs, you may not make as much of an antibody response to vaccination or natural infection. Evusheld is a way of getting around that. We're just giving you antibodies, saying, here, have these, have this protection. Just 2 weeks ago, the FDA authorized second doses of Evusheld 6 months from the first dose. So yeah, I am a believer in Evusheld. I do think it offers protection against COVID, including the Omicron variants that we're seeing out there.
Good. Kimia is asking, actually telling you that she was diagnosed with MS in July, and her neurologist wants to put her on Tysabri. She just wants to know how you feel about that.
So there are two schools of thought on how we use the disease-modifying therapies. You know, when we're picking an initial treatment, like for someone like her. So one school of thought says, I'm going to pick a modestly effective drug with a great safety profile. So maybe one of the platform therapies or an oral therapy. The other school of thought says, I'm going to pick a more effective therapy like a Tysabri or an Ocrevus initially. There's no right or wrong. I would say most comprehensive MS centers in the US are leaning more towards that more aggressive treatment up front. I like the thought of being aggressive up front with a drug like Tysabri. One of the questions we get sometimes, if I was diagnosed or if my family member was diagnosed with MS, what would I want to be on up front as my first line treatment? I would rather be on a more effective treatment early on. We have to balance that effectiveness with the safety. And so, there are certain safety things we need to do with these more effective therapies. So like with Tysabri, we want to make sure we're rechecking that JC virus antibody index on a regular basis to make sure people stay in that good safety range. But I like that option.
Darcy's asked if you could discuss efficacy of Kesimpta versus Ocrevus for newly diagnosed relapse remitting MS cases.
So both Kesimpta and Ocrevus are anti-CD20 monoclonal antibodies. So these are B cell therapies. They have the same mechanism of action. The real difference is in the kind of the route of administration, with Kesimpta being a once monthly subcutaneous drug, Ocrevus every 6 month IV. There's never been a head-to-head with those two drugs. So it's not like we can show you a study and say that one's better than the other. I think most of us feel, because the mechanism of action is the same, that they should be awfully close to one another in terms of their efficacy.
Thank you. There's a question regarding having a hysterectomy. And now they said, obviously, going into early menopause because of that, which could cause temperature regulation issues and relapses. but is there something good about getting your energy back by not having your monthly periods? I mean, is there any opinion on that?
Yeah, so there have been studies that have looked at women who are perimenopausal and postmenopausal to see what that does to their MS. And overall, there's not a dramatic effect of MS. We know that estrogens can impact MS, but the most dramatic impact we see with estrogens is really pregnancy. With estriol being the estrogen that spikes during pregnancy, that seems to have a protective effect on pregnancy. Some women will say that their symptoms seem to act up a little bit in maybe the week before their period, but it's not a true relapse. It's more, symptom fluctuation. Overall, we don't see a dramatic effect of natural menopause or sort of induced menopause with a hysterectomy on women with MS. The challenge in looking at that is as women are getting older and going through menopause, there can be sort of just the natural effect of aging in both men and women on their MS. So we do sometimes, as we slow down, as we just age naturally, sometimes it's difficult to tease that out from, what is MS progression versus just natural human aging. But overall, I don't see a dramatic effect of hysterectomy or menopause on what MS is doing. The temperature the hot flashes we see, with in menopause and perimenopause, I think that's more of a hormonal symptom than a true increase in your core body temperature. We don't think hot flashes bring on true relapses. It may make your symptoms feel temporarily worse, but it's not causing true MS relapses or exacerbations.
Thank you. Judy's asking, in general, is there any protocol for those patients on Ocrevus infusions or other BT lymphocyte depleters when it comes to scheduling routine procedures like dental cleanings, podiatry, or routine colonoscopy?
Yeah, so ideally, we think that once people are on a B-cell therapy, that their immune system is fairly homeostatic. You could argue that right after an Ocrevus infusion or in the day after your Kesimpta injection, that maybe your B cells are at their absolute lowest. So if you had the option of and the leeway of thinking about when to schedule a procedure, I think with an Ocrevus where you're doing a 6-month infusion, if you could do it at the midway point, in theory, that makes the most sense to me. I don't know that it makes a dramatic difference. I think just to avoid any confusion, maybe trying to avoid doing it in the 2 weeks before or the 2 weeks after, try to get it at that midpoint would make the most sense to me.
Thank you. Dean is asking, in the new setting of the disease-modifying medications and decrease in MRI visible lesions, how do you decipher if someone has transitioned from secondary or into secondary progressive?
Yeah, I think that's one of the hardest things that we look at in the real world is that decision. Because when you think about those terms, relapsing, remitting, and secondary progressive MS, those were categories that were designed really before there were disease modifying therapies, and they were really thought of in how we describe MS in people who aren't on treatment. So now I come along and I put people on disease modifying therapies, and what I may do with your disease modifying therapies, I may stop your relapses, I may stop your new lesions on MRI, but maybe you're still seeing a little bit of progression. That's not the natural history of your MS. There's a temptation to label that person as having secondary progressive MS when really we're seeing some modified version of their MS due to their treatment. I'm very leery about using that secondary progressive label in people who are on treatment. If we really wanted to know what the person's MS was doing, we take them off treatment and look at their natural history. Well, we don't want to do that either. I mean, we don't want to see your MS progress. So along the lines of secondary progressive, it's important that people realize too that we're now sort of subdividing that into with activity and without activity. Secondary progressive MS with activity is the person who is still having relapses and or new lesions on MRI along with their progression. without activity is secondary progressive MS with no relapses, no new lesions on MRI. So we are doing that subdivision now. So it's not easy in the real world to sometimes know for sure when someone has made that transition. And just to be completely honest, in the real world, we're sometimes a little leery of using that progressive label just for fear that are we going to give an insurance carrier ammunition to say, well, maybe your disease modifying therapy is not really approved for that progressive form of MS, and now are you going to get a hassle from your insurance carrier, about you having the wrong label to be on the therapy that you're on.
Elizabeth's asking, how efficacious is Mavenclad for primary progressive MS?
So primary progressive MS is a tough one. We technically only have one FDA approved treatment for primary progressive MS, and that's Ocrevus. That's not to say we might not want to try other things, but if we're just playing by the rules, really the only Ocrevus is FDA approved for primary progressive MS. The challenge with pure progressive forms of MS like primary progressive is most of our disease modifying therapies are in some way anti-inflammatory. And there's just not as much inflammation with primary progressive MS as there is with other forms. It is more of a neurodegenerative process. That's not to say there's not some inflammation there, but the target that we're shooting at with our disease modifying therapies is just smaller with primary progressive MS.
Okay, great. So now Debbie's asking, I tested positive for the JC virus and I'm on the generic for Tecfidera. Should I be concerned? How should I be monitored?
So you realize that lots and lots of adults are going to test positive for JC virus. It's a very, very common virus. Many adults carry it, and it doesn't cause any illness unless our immune system is altered. I think with Tecfidera, it's really important that you get regular blood testing. And so what you want to look at with those blood tests is your lymphocyte count. The overwhelming majority of PML cases that have developed in Tecfidera, and the number has been small, have been in individuals who have very low lymphocyte counts. So if we, meaning the medical community, if we're doing our job appropriately and we're monitoring your lymphocyte count, your risk of PML should be incredibly low, even if you're JC virus positive. So I will say, and this is just us at our MS Center, we take it a little further. We do the total lymphocyte count. We also break that down into the subsets of lymphocytes. We look at your CD4 and CD8 counts. I want to make sure that all of those numbers, total lymphocyte count, CD4, CD8, are all normal. Some would argue that just the total lymphocyte count is enough, but at a minimum, make sure you're getting that done on a regular basis. For us, we do it twice a year, so it's on an every 6-month basis.
Okay, so I thought I asked you this, but I was told that I didn't. But so here we go. I'm sorry, Darcy. Darcy's asked, can you discuss efficacy of Kesimpta versus Ocrevus for newly diagnosed relapse remitting MS cases?
Yes, I think we did hit that one. So again, same mechanism of action between those two drugs, both B-cell therapies. No studies comparing the two head-to-head, but I think most of us feel like that the efficacy should be very, very similar between those two drugs. I think picking one or the other probably comes down to, I think some personal preference, convenience, accessibility of those two drugs. But no head-to-head studies to date on those two.
Thank you. Tara's asking, I'm on Gilenya as my first and only MS medication, diagnosed December 2016 and on Gilenya since January 2017. Undiagnosed probably since 2006. No new lesions on yearly MRIs. Doctor is saying I've continued to get worse since diagnosed due to old lesions. Let's see. I'm sorry, since there's due to old damage. How do you feel about Gilenya? And does the old damage making me progress make sense?
So Gilenya is a great drug. So it's in that class of drugs called S1P, modulators. They all of those drugs. So Gilenya, Ponvory, Zeposia, and Mayzent work by locking up some of those inflammatory lymphocytes in the lymph nodes and not letting them get out and cause active inflammation. They are effective drugs. With any disease modifying therapy, what we would like for you is, number one, you're happy with it. You're not having side effects from it. And then we want no relapse, no progression of disability, and no new MRI lesions. If you're getting all of those three things, we're happy with it, and you're happy with the drug, and we're happy. If you're not getting one of those three things, so you've had new lesions on MRI, you have relapses, or you're having progression of symptoms, then we've got a decision to make. Is there something more that we could do? One of the challenges we have when the person has a stable MRI, but they're getting worse, is that true disease progression, or could it be from the old lesions? When we say someone's getting worse from old lesions, what we think is happening is that the person is losing neural reserve. So it's not that the MS lesions are changing, it's your brain's ability to adapt to that old damage that is changing. And all of us as humans lose neural reserve after about age 30. So maybe your brain was able to handle that damage from the old MS lesion, but just due to normal human aging, that lesion is giving you more trouble. That's a very difficult thing to sort out. So how do we know whether it's true progression of disability from your MS or it's loss of neural reserve? There's not an easy way to know that right now. There is a lot of work out there with something called neurofilament light chain. This is a blood test or a spinal fluid test that we could do to look for damage in the brain or spinal cord, resulting in increased levels of this neurofilament light chain that might help us sort out, is this loss of neural reserve or is it ongoing damage from your MS? I think because we're not at a perfect state of being able to distinguish those two, and someone like herself, we at least have a discussion with them about maybe we need to think about changing therapies and moving to something that could be potentially more effective.
Thank you. Can you discuss your observations of symptom improvement with B cell therapies, particularly fatigue, slow cognition, and hand tremors?
So one of the things we've seen with these more effective therapies like natalizumab and ocrelizumab is this small subset of people who start one of these therapies, and with any of these therapies, our goal is that no progression, no new lesions on MRI, no relapse. Some people do better than that. They get those three things and they see a symptom improve. And we think it's real. It doesn't happen for everybody. And when we start one of these treatments, we want to have realistic treatment expectations. We don't want to set an unrealistically high bar and say, we're going to make you better. If we make you feel better, that's wonderful. We'll take that any day of the week. We don't really understand how that's happening. We don't think these more effective therapies are directly repairing damage in the brain or spinal cord. What they may be doing is stopping the inflammatory process so effectively that natural repair mechanisms have a chance to kick in. So our brains and spinal cord don't repair themselves as well as bone and muscle and skin do, but they do have some repair capability. And maybe by stopping the attack with multiple sclerosis, the inflammatory attack, we're letting those natural repair mechanisms kick in. So we do hear people on more effective therapy say, a certain symptom got better, my energy levels got better. With natalizumab, it's not unusual to see this kind of like people are filling their gas tank when they get their infusion, and then 3.5 weeks later, as they're coming due for their next infusion, they say, man, I'm having this wearing off effect. My energy levels are lower, my legs dragging a little bit more. I come in and get my infusion and bam, I'm good to go again. We see some of that with Ocrevus as well.
Thank you. Murray's asking if you can speak to the MS hug experience and how best to manage that.
Yeah. So MS hug, it's one of those funny words in MS. You would think a hug is going to be a good thing, and this is more like being hugged by a grizzly bear. Maybe not a good thing. So it's usually a belt or band-like sensation. It can be around the upper chest, the lower chest, the abdomen, and it can be described as anything from a hug, a squeezing sensation, to a really bad squeezing sensation, to sometimes actually sort of hypersensitivity to touch in a band or a belt-like distribution. We think that the MS hug can be from one of two things. It can be a form of spasticity, so you might manage it just like you would manage spasticity, or spasms. You could think about baclofen, tizanidine, any of the drugs that are therapies that we would use for spasticity. Normally with spasticity, we think of stretching as a really important thing to do to manage that spasticity. Stretching is pretty hard to do with an MS hug. There's really not an exercise we can do to stretch those muscles out. So spasticity could be one thing that causes the MS hug. The other thing that could cause it is that it's a sensory alteration. So dysesthesias. If you have an extra feeling, an extra sensation, like water's running in your leg or you're tingling, we call that a paresthesia. If your paresthesia becomes uncomfortable, then it's a dysesthesia. We think in some people the MS hug could be a form of a dysesthesia. We normally manage those things with medications like gabapentin, Lyrica, duloxetine. So these are usually drugs that are either anticonvulsants that we've repurposed into managing this uncomfortable sensation, or they're antidepressants that we've repurposed into managing this sensation. We can also think about medical marijuana or cannabinoids for managing the MS hug. And the beauty of cannabinoids is they could cover either cause. So they can be useful in managing spasticity. They can be useful in managing dysesthesias.
Thank you. Kimmy is asking, can one take any natural supplements to encourage remyelination?
Not that we know of yet. So I would say, the whole area of neural repair and remyelination is vitally important to all of us. It's an area that a lot of research dollars are going into, and we don't have an FDA approved option, a pharmacologic agent or a natural agent that we know of yet. Hopefully, that's going to be a different discussion in the next few years, that we will have something to offer. I think right now we want to do everything humanly possible to prevent new damage, so that when we do have an option, whether it's natural or pharmacologic, that the person has less damage to have to repair in the first place.
And someone's asking about the studies on glutathione and the impact on MS. And some have found a lot of help with stuttering, word recall, and muscle maintenance.
Yeah, so glutathione, I think, would probably fit into that latter category of maybe a supplement that is being looked at for symptom management. And we don't really know the mechanism of action. The studies have been mixed so far. There have been negative trials. There have been some positive trials. I think it falls into the category of probably reasonably safe. So if someone, I'm not on the bandwagon yet of recommending it for patients widely, but I'm certainly not going to argue with someone if they want to try it out. I think it's something that is probably not likely to have any harmful effects, and could be helpful.
How about the Adderall?
Yes.
Can that natural supplements and medicines good for energy, such as Adderall?
So, fatigue has always been the most common symptom people with MS have, and I think for many people it's their presenting symptom, and so and the irony of that is, here it is, the most common thing that people with MS deal with, and there is no FDA approved treatment for fatigue in MS. We try lots of things, and I think there are a lot of effective treatments, but there is no FDA approved option. So Adderall falls into kind of the stimulant class. So Adderall, Ritalin, medications like that certainly play a role in managing fatigue in MS. You've got amantadine, the old school anti-influenza drug. You've got modafinil and armodafinil, so that's Provigil and Nuvigil, are something that we certainly use. In this next MS Focus magazine that we're coming out, I just reviewed 2 articles that came out. One looking at just coffee, caffeine, and it showed that it was of benefit for managing fatigue and MS. And then a nice one from a more of a natural standpoint was lavender. So we normally think of lavender as something that would help with stress and anxiety, maybe help you sleep at night. But this study specifically looked at fatigue management, and it was a placebo-controlled, double-blind placebo-controlled trial. And the group of people with MS on lavender clearly had better energy levels. Lavender's inexpensive. It's going to have a very low side effect risk. In this study, they looked at capsules containing 600 milligrams of lavender, and it was helpful for fatigue.
Thank you. And I see a couple of times, I'm hoping that everybody can see that Gus has posted a link for the clinical trials. If not, then we'll make sure we put it into a different site, but I think he shared it with everyone.
Awesome. Thank you,
I'm
Gus.
hoping. Yeah, thanks, Gus. So do you have any experience with the new PONS treatment? Karen wants to know.
Yeah, so so the Pons is a neural stimulator. It was developed largely through some work with the Department of Defense, and so we're very interested in repair strategies. And I would say the Pons, the PONS unit, is sort of in that camp. But rather than repairing damage, the thought is that it actually reroutes, that it's sort of tapping into neural plasticity. If I can't repair the area of demyelination, what if I could just form new pathways around it? So what they did with this neural stimulator is they had a group of people do very aggressive physical therapy. This was 5 days a week physical therapy, and most of the patients, at a minimum, it was three days a week of physical therapy. And they used this headset. It looks like it would be, sort of, headphones with a microphone coming around, but that microphone piece is actually the neural stimulator. It's a little tab that goes under the tongue. So you wear this during your rehabilitation, and it delivers a micro electrical current. And the idea is that it's helping you form these new pathways. So it's a combination of that device and the aggressive rehabilitation. Jury is still out. It looks very exciting. So we are looking at it here at Shepherd. It's very labor intensive on both the person with MS's part and the healthcare provider's part, because we've got to figure out how to get large numbers of people in for at least 3 days out of the week of physical therapy. So yeah, I think it's an exciting development.
I don't think I asked you this, but James wants to know how you.
Oops, you froze up there, Deborah. You froze up for a second. Can you ask that again?
How do you feel about Vumerity?
Vumerity it's a great drug. So Vumerity is an oral therapy. It's fairly close in molecularly and in terms of its mechanism of action to dimethyl fumarate or Tecfidera. The Vumerity was studied and found to have a lower risk of GI side effects compared to Tecfidera, but otherwise the mechanism of action very similar. So what you like about Tecfidera, you're probably going to like with Vumerity. Again, in the real world, one of the advantages of Vumerity is it is still a name brand product. There's no generic on it. Normally we think of generics as being a good thing, and they can lower the price of a drug. But one of the challenges when we see generics developed is sometimes we lose the copay assistance from the drug manufacturers. So there is still good copay assistance through Biogen for the Vumerity product. So yeah, I think it's an option worth looking at for people.
Thank you. Linda's asking that she recently read an article on possible causes for disability progression when an MRI is stable. I can't recall where it was published, but it mentioned that brain atrophy may be a cause. Wouldn't brain atrophy be seen on the MRI?
Yeah, that's a great point. So I think atrophy kind of goes into that bigger discussion about loss of neural reserve. The challenge that we have in the clinical setting is making a judgment call about atrophy. So in most clinical settings, when we look at your MRI, we can see the atrophy, but in most clinical settings, we're not using computer-based models. We're not objectively measuring that atrophy. We're getting better at that. So there are now different systems in place that would give us actual hard numbers for what your brain volume is. Outside of that, when we look at someone's MRI, it's very difficult outside of drastic changes in atrophy for me to look at your MRI from one year to the next and say that your atrophy is more or less on this MRI versus that MRI. The other thing that is a little humbling is our brain volumes can change throughout the day, depending upon your state of hydration. So if you're really well hydrated in the morning versus dehydrated in the afternoon, your brain volume may look a little different. And so it could affect the way we think about atrophy versus not having atrophy. So she's right in theory. I think the practical parts where the challenge is in objectively measuring the atrophy.
Thank you. And we have someone who said that they have a right bundle branch issue, and they're wondering if that's an issue to get Evusheld. The cardiologist that they use said he has no experience with it, and this person said they've been on Ocrevus.
So I think that if you look at the product information on Evusheld, they're really talking more about people who have had myocardial infarcts, heart attacks, ischemic events. To my knowledge, the right bundle branch block, which is not an uncommon incidental finding on EKG, to my knowledge, that is not a contraindication to the Evusheld. We also have to be honest and say, Evusheld is FDA authorized. It is not FDA approved. So it, like the vaccines, because of the kind of the emergency situation of the pandemic, it got authorized without 3-5 years of data, like sometimes things have before they get FDA approval. So we don't have years and years and years of data on Evusheld. I would say in our experience, we've been very happy with it. We have administered over 400 doses of Evusheld, mainly to people on B-cell therapies like Ocrevus, but also to the S1P therapies, and we have not seen any issues with the drug. Evusheld is not generating an immune response like a vaccine. So when we give you a vaccine, we're asking your immune system to do something, to make a response to that vaccine. Evusheld is passive. It's monoclonal antibodies that are just passively protecting you should you be exposed to COVID.
Karen would like to know, how have your patients who are in their mid-60s handled switching from Ocrevus to Mavenclad, hoping to do Mavenclad and just be done?
Yeah, so we've not had hundreds of people doing that, but that is a kind of a niche where we think Mavenclad may be a good fit. So we know that people with MS may at some point be able to stop their therapies, and we normally start having that discussion when people in their 60s. So it's totally understandable where she's coming from. So the idea of Mavenclad is, I'm going to do my one oral treatment now, a year later do another treatment, and I'm done. And then I just let my immune system sort of naturally calm down so that Mavenclad is the last therapy. So I like that idea. It makes a lot of sense. Again, we don't have hundreds of patients who've done that. We have a handful of people with that experience, but I think that makes sense.
Emma says she was diagnosed in 2016 with relapse remitting MS. Her main symptom is dizziness. She's on 40 grams of Brabio injections 3 times a week. When she was pregnant, her symptoms disappeared, but she was wondering, as her dizziness is constant now, she wants to know if the MS was just getting worse.
So when you have a symptom, it doesn't matter if it's a walking issue, visual issues, dizziness, there's always that chance that because of where that lesion is at, that it's going to always be there. And so just because the symptom is persistent, that doesn't necessarily mean that it's an indication of her MS progressing. It may be just, you had an area of demyelination hit in a very sensitive area that's going to give you trouble. If this is true vertigo that she's dealing with, it's a really bothersome symptom. Vertigo is one of those things you can't ignore it. I mean, if the room is spinning, you're gonna notice it. We use a lot of vestibular rehabilitation. So there are physical therapists who specialize in working with people with dizziness. There are neuro-otologists. So these are neurologists who've done special training in working with people with vertigo. So if she's not looked into one of those things to help her manage the dizziness, I'd have her think about that, because it can make a big difference for managing dizziness.
Patricia has something nice to say. She said she was diagnosed in 2017. She did not feel heard by her VA assigned neurologist and always left appointments feeling frustrated. She's learned so much from these town halls and other online content that you and others like Dr. Boster so generously provide, that she realized it was time to advocate for herself and request a new neurologist. She said, "Thank you."
Good for her.
Her first appointment is coming up, and she's wondering how to make most of the time with her. What do you like to see, hear from new patients? Great question.
That is a wonderful question, and thank you. We're Dr. Boster and myself and others who do this, we're happy, and we feel very honored that people with MS trust us to be a part of their lives. We know that's a big deal, that it's a very long-term and intimate relationship, and there's a trust factor, and we appreciate that trust. I think different healthcare providers may have different things they work, but I think having a concise little written history sometimes is a nice thing, where if you could put down, in 2 pages, this is my MS story. This is the year I was diagnosed. This is the year I started treatment A. This is the year I switched to treatment B. Why did I switch to that? So just a nice little timeline sometimes is helpful. Having a printed or written list of your medications, because it is always a nice thing, because we can, with our electronic medical records that we use now, being able for me to look at it, to hand that to a nurse, for them to now put that into your permanent record is a nice thing. Having a list of what your concerns are, so maybe your top 5 questions or needs that you want to have addressed. And I know it sounds silly, but put your most bothersome concern as number 1. It's interesting, sometimes we'll have people bring their list in and they've got 10 things they want to have addressed, and they put their most important one at number 10. It's like, no, put your most important one number 1, so we make sure we give that adequate time to address that.
Perfect. Gillian said, can someone switch back to interferon after using another drug because it's not working?
Yeah, absolutely. So one of the important things, now that we have so many treatment options, is to think about that kind of succession planning. So what do I do if the treatment that we select together for you isn't working? What's the exit strategy? With some drugs, it's pretty easy. So moving from, say, a Tysabri to an interferon, or those are not hard decisions. Where it gets a little more challenging is when you have a drug with a very long duration. So a lot of our medications, the drug itself may not stay in your system a long time, but the effect on your immune system may be long lasting. So Ocrevus, for instance, Ocrevus is not staying in your system for 6 months, but the immune effect lasts for 6 months for most people. So how do we think about the timing if we're going to switch you to something else? Mavenclad would be a good example. What do we do if we're not happy with someone who's on Mavenclad, and think about the timing of that. But for most of the time, using one drug is not going to take something else off the table, especially an interferon isn't going to take that off the table for you.
Thank you. We have 2 questions similar, so I'm going to tell you, they may be from 2 different people. So one is, for those of us who are 60 and older with relapse remitting MS, what are your thoughts on discontinuing medications? They've heard different schools of thought on this. And the other one was, how long can you stay on disease modifying treatment?
So there's no strict time limit on how long you can be on disease modifying therapies. And so, when we have this discussion with a 30-year-old who's starting treatment, we tell them this is for the long haul. we will probably start having a different discussion with you at age 60. But for right now, let's plan on this being the long-term plan. So one of the studies that was presented at the Consortium of MS Centers this spring was a study looking at discontinuing treatment. This was a large study of around 300 individuals. They were generally 60 and over. Most of them were on either an interferon or glutamer, and they randomized these folks with their permission to either staying on their treatment or going off of their treatment, and then they looked at them 2 years later. The good news is that the overwhelming majority of people were doing fine. Most people were not having relapses or progression. What they saw in the group that stopped treatment is that 3 individuals did have a relapse. They tended to be mild. In the group that stayed on treatment, 1 person had a relapse. They did not feel that that was statistically significant between those two groups. So in the real world, we will start having that discussion with people at about age 60. But we tell folks there's no right or wrong answer to this. So there are 3 things that people need to think about in making their decision to stay on treatment or maybe discontinue it. How stable is my MS? What's the psychology of me stopping my drug? Am I really, do I like that security blanket of being on a treatment? And am I going to lose sleep at night if I stop it? That may be a reason to stay on treatment, just because you like the security of being on something. And then what is the financial, hurdle that you're facing to stay on that treatment? Is your insurance covering 100% of that drug? There's no financial hardship, or are you getting killed with a copay every month to be on that? So those are the things that I like to see people kind of factor in. And then there's a 4th part to that discussion. So many of people with MS are on vitamin D replacement therapy. I do think vitamin D has legitimate immunomodulatory effects. So when let's say we decide to stop an interferon or a glutamer or one of the other treatments, we may still be leaving that person on vitamin D. So it's not like you're completely unprotected. I think you're still getting a protective effect. I like to, if we're going to stop treatment, I like to think about repeating an MRI about 6 months later, just to make sure we're not getting any surprises under the surface, that there aren't lesions that are popping up for that individual. But yeah, it's an area of a lot of research. Well, we would love to have a biomarker, a blood test that said, yes, it's time to stop treatment. We don't have that right now. So it's a joint decision between the healthcare team and the person living with MS.
And so what's the best approach to prevent lesions if they started on the spine and most likely not on the brain? Is medicine the only approach to prevent lesions?
So, we like to think that, a healthy lifestyle that, minimizes inflammation. There is some evidence out there. There was a study that I just looked at, looking at the Mediterranean diet. I just looked at a study on intermittent fasting, and there's some thought that healthy diets may reduce inflammation. We don't have a study that shows that definitely equates to fewer MRI lesions or fewer relapses, but you would think it should. So I think having a healthy diet, there are researchers who believe that regular exercise has anti-inflammatory effects. I think there's certainly a lot of other benefits to regular exercise. Outside of those things, don't smoke. If you're not smoking cigarettes, don't start. We know that acrolein in cigarette smoke is inflammatory. It doesn't make your immune system very happy. So don't smoke or stop if you are. Outside of that, I mean, if someone has spinal cord lesions, the spinal cord is less forgiving than the brain with demyelination. So if you have a lesion in your spinal cord, it's a lot more likely to give you symptoms than a brain lesion. So we do encourage people to find an appropriate disease modifying therapy along with all of these healthy lifestyle things that we would hope to do. So use every tool in your toolbox to prevent yourself from having new lesions and prevent future disability.
Russ is asking if he can give blood while on Ocrevus that he just started a month ago.
So the Red Cross, different Red Cross locations may have different sort of rules and regulations. They're going to, strictly speaking, there's no direct contraindication to donating blood. If you're on Ocrevus, I would certainly want to make sure that you have a healthy hemoglobin and hematocrit before you think about giving blood, that your platelet counts are normal. They should be in a person on Ocrevus, but you may run into individual Red Cross locations where they may have certain rules about donating or not. But strictly speaking, I don't know of any direct contraindication.
Darcy wants to know how much time is best between Hep B and Pneumovax vaccination series and starting B cell therapy?
So ideally, so if you're not on a B cell therapy, you would like to complete your vaccinations about 6 weeks before starting your B cell therapy, really let those vaccines do their thing immunologically. In terms of, taking multiple vaccinations at the same time, there's not really a contraindication between doing a lot of vaccines at once. I like to put about a month between different vaccines, just so you're not whacking your immune system from several different angles at the same time. Anytime we do a vaccine, there's always the potential that you're going to feel a little bit crummy. I think if you're doing 2 vaccines at the same time, there's always that potential you could feel crummier. So if you can, just try to put a month or so between the different types of vaccines, and then 6 weeks. Complete that series 6 weeks before starting your B cell therapy.
And Gus wants to know, as a parent with MS, when testing your children for vitamin D levels, what should the nanomoles levels be for children?
So it's really the same as adults. So in most labs, it's your normal is going to be between 30 up to 70 or 80, depending upon the lab. I like to see people in the really normal range. So, technically 31 is normal, but it's barely normal. So in most of the MS trials have suggested 50 seems to be the range where you get some protection from the vitamin D. So I'm really in both children and adults shooting for blood levels between 50 and 70 in that range.
I'm not quite sure what Joe's talking about when he says this, but he says, what route of drug should one take when their lymphocyte count stays down? And should he take magnesium with his vitamin D?
So your lymphocyte count, if you're on a drug that lowers your lymphocyte count, so you could be on a Tecfidera, you could be on a B cell therapy, those drugs can lower your lymphocyte count. I like to see people's lymphocyte counts above 500 in general. The challenging one are the S1P drugs, your oral therapy, your Gilenya, Ponvory, Mayzent, Zeposia drugs. Those drugs are designed to lock up lymphocytes in your lymph nodes. So people's lymphocyte counts are falsely depressed on their blood counts. We can't measure the lymphocytes because they're locked up in the lymph nodes. What level of lymphocyte count, though, is unacceptable in a person on an S1P drug? We're a little more forgiving with those. I will let those counts go as low as 200 if you're on an S1P drug, because I know the cells are there. I just can't measure them. I don't feel strongly about magnesium with vitamin D. If I'm just trying to correct vitamin D deficiency, I don't really advocate that people take magnesium with it. We're typically using very big doses of vitamin D in our MS population that are vitamin D deficient. I usually have people doing D3, 50,000 units once a week. That preparation doesn't come with magnesium in it. I actually use more magnesium to treat migraine headaches and sometimes leg cramps than I do with the D deficiency.
So this person's saying for their last Ocrevus infusion, they had inquired about the possibility of receiving them more often because they were experiencing greater fatigue and a symptom exacerbation between the infusions. They agreed to every 5 months rather than every 6. However, this person didn't realize that they would receive half the dose than if they had continued on the 6-month schedule. Receiving half the dose doesn't make sense in exchange for receiving 1 month sooner. What is the thought and reason behind this? Is this driven by insurance?
So there are a lot of parts to that question. So they need to have a discussion with the healthcare team and say what was the thought process on lowering the dose. So Ocrevus is FDA approved to be given as frequently as every 5 months at the full dose. So if you read the product information on Ocrevus, they say, so in the product information, they say 6 months, 6 months, 6 months. Oh, by the way, it was studied at 5 months also. So if someone's having a wearing off effect at 5 months, it is FDA approved to be given at 600 milligrams every 5 months. Insurance companies will sometimes not want to pay attention to that little clause in the product information. So I have seen insurance carriers fight back against the 5-month infusions. The thought on lowering the dose is there is data out there with the sister medicine to Ocrevus, Rituxan. So there was a Spanish study, 2 MS centers in Spain, that looked at treating relapsing remitting MS with the full dose, 1,000 milligrams of Rituxan, which would be the equivalent to 600 of Ocrevus, versus half dose. And they did this from day one. So one group of MS patients did full dose Rituxan, the other group did half dose. At the end of 2 years, there was no difference in the efficacy between the full dose and half dose of Rituxan. What they did see in the half dose was a lower risk of infections. So there are MS centers out there that are dropping the dose on Ocrevus based upon that Rituxan study. I think this really gained some steam with the COVID pandemic. So when the Delta surge with COVID hit, we saw some of our B-cell therapy patients, even those who were vaccinated, getting really sick with Delta, and so the Ocrevus Rituxan population. So it made us start wondering, well, could we give them, the same degree of protection with a half dose of Ocrevus while still, and increase their COVID protection? That should really be a discussion that they probably should have had with you, rather than just lowering the dose. So I would ask them what their thought process was. It's not crazy though. So for the person asking the question, that they still may get a lot of protection and get rid of that wearing off effect with 300 milligrams of Ocrevus every 5 months.
Thank you. Elizabeth's asking about how long does it take for T cells to come back after getting off of Tecfidera? They just switched from that to Ocrevus, so just getting a little nervous about having both the T cells and the B cells.
Yeah, so we do see the lymphocyte counts drop in some patients on Tecfidera, and that's primarily the T cells, like this person's saying. In patients that I took off of Tecfidera due to low lymphocyte counts, I mean, most of them bounced back within a month. I did have some people, though, that it lingered for a long time. And I saw patients having low lymphocyte counts for well past a year. And that is a challenge. So there's that balance between not wanting the person to be unprotected from their MS, but like she's saying, not wanting to whack them, from the 2 different angles, B and T cells. So I think that they're just going to have to follow, if they're starting Ocrevus, they're just going to have to monitor both the B cells and the T cells. Most of the time, those T cells will start bouncing back a month after stopping the Tecfidera.
What is your top drugs? Karen wants to know. For someone over 65 and MS for 25 years, was on Ocrevus and stopped from respiratory infections. Doc doesn't think Gilenya is safe. So to be on long-term when older, your thoughts?
So I guess one question was, does the person need to be on anything? So based upon the study that was presented at the consortium of MS centers, maybe they could only do something easy like vitamin D and not have to restart a disease-modifying therapy because their immune system is in a better place than they were, say, when they were, in their 40s. If we're going to start something in someone over 65, I do like Aubagio or teriflunomide. I think it's a nice niche-y drug. Maybe not always a great drug for the 20 and 30 somethings because of some issues maybe with family planning. But in someone over the age of 60, I do like the Aubagio as an option if we need to start anything.
Okay. This might be our last one. We're going to see, maybe we'll do one extra, but Jerry says they have progressive MS, not taking any DMTs. Progression continues, no new lesions, but doc changed diagnosis in May to SPMS in order for her the doc changed this to be a part of the Hercules study using the drug is, I can't pronounce it, can you say that?
I think it's total. It's one of the BTK inhibitors.
Thank you. Any
Yeah.
thoughts as to how safe this is? They'd like to know whether they should hold off or get a second opinion.
So, I mean, the drug is in phase 3 testing. So, we don't have the completed trials. If that's the BTK inhibitor that they're looking at, one of those trials did just get halted by the FDA because of some liver function abnormalities. I like the idea of clinical research for people with primary progressive MS or secondary progressive MS without activity, because we don't have great FDA-approved treatment options. Anytime you're in a clinical trial, we have to admit we don't have the final answer. We're looking for how effective this treatment is and how safe it is. The beauty of being in a clinical trial is that you're probably being monitored as closely as humanly possible. The amount of lab testing and clinical follow-ups and research is usually a little bit more than in the regular clinical setting. So yeah, I think that any clinical trial is worth looking at for someone with secondary progressive or primary progressive MS. Whenever we're doing a clinical study, if you're thinking about participating in one, you need to know all the details, really make sure you understand what you're signing up for. Many trials in progressive forms of MS are placebo-controlled trials. And so those are usually double-blind placebo-controlled. So people are randomized to be in one of those treatment arms. If you're in that kind of study, you don't know if you're on active treatment, and we don't know if you're on active treatment. That's the double blinding part. We're both blinded so that we're not biased one way or the other.
Thank you. Doc, do we have time for one more?
Sure, absolutely.
So Michelle said that she noticed that after her last flare-up, she was having problems with sentence grammar while typing and texting. Which part of the brain controls that? And is there any medications or treatment that can help her?
So generally language functions, assuming you're a right-handed person, they're going to be more on the left side of the brain, usually kind of left parietal, but then it's spread out through the left hemisphere. If you're left-handed, your language functions can be more on the right side of the brain, or they may be spread in both hemispheres. Interestingly, if you look at left-handed people, they generally do better after strokes because their language functions are spread out between both hemispheres. It's not localized in just one like right-handed people would be. We don't have a medication yet that is going to repair that damage. Working with a speech language pathologist to help sort of recover from that. We do think that therapies, whether it's physical therapy, occupational therapy, speech language therapy, it probably helps promote some of that neuroplasticity or rerouting. There are studies showing that if you look at people after an MS relapse who just received steroids versus steroids and rehabilitation, the rehabilitation clearly promoted better recovery than just steroids by themselves. We do hope we are getting closer to a day when we have neural repair strategies, whether it's mesenchymal stem cells or any of the many other things that are being looked at out there that will hopefully help people like herself and others with MS, reverse disability.
Thank you. So that brings us to the end of our time. Thank you for staying a little bit longer. If you missed any part of this conference, it has been recorded and it's going to be played again on our MS Focus Facebook and YouTube channels. Reply to your registration email for any information on how to access our recordings or sign up for our newsletter or upcoming events. For those of you that we didn't have the time to get to your questions, next month we're going to have Dr. Boster answering Q&A. And the month after that will be Dr. Thrower again. So if you can wait, write down your question and you can ask that to either one of them next time. Our next teleconference is going to be Wednesday, August 24th. And that's going to be at 4:30 p.m. Eastern time. And that's going to be with Dr. Sabine, forgive me, Lulu. And she's going to be talking about who will be, actually, she's going to be talking about lifestyle, health, and diet in MS. Should be very interesting. As you leave the conference today, a survey will appear on your screen. We ask that you just take a moment to fill it out. It shouldn't take more than a minute or so. And that's going to give us a sense of what you really want to listen to, what you really want to hear, what's most meaningful to you. So our sincere thanks to all of our attendees for your participation, especially to Dr. Thrower, who always takes time out of his very busy schedule to be with us and answer all of our questions. You're like the Energizer Bunny, because I feel like I just want to give you a break for a second to take a breath and drink a glass of water, and you never need it. So anyway, thank you so much for coming with us, and goodbye, everyone. Have a great day.